In this talk, we're going to look at the recognition and management of the critically ill ward patient. The objective is that we recognise why managing critical illness on the ward is difficult, and furthermore, we're then going to look at developing a system for ourselves to try and make it just a little bit easier. Before we can do any of that, we need to think about what is critical illness. We define critical illness as any disease process which causes physiological instability, and furthermore that instability is likely to lead to disability or death within minutes or hours if we don't intervene in the meantime. Most immediate life-threatening effects come from disruption to the neurological and cardiorespiratory systems. When you look at the management of the critically ill patient on the ward, it's unfortunately true that there is very often a suboptimal approach to things. As long ago as 15 years ago now, it was identified that there's often a lack of a systematic approach. You know all too well that ward staff can be overburdened, and perhaps less true than it was, but we do still find deficiencies in people's medical training. When you look at cardiac arrest on the ward, it's often preceded by many hours of untreated physiological deterioration. Patients tend not to arrest out of the blue in hospital. Out of hospital, yes, but in hospital there's sadly often a general trend towards deterioration. The real problem is one of a signal to noise ratio. Critical care is relatively easy. All the sick patients are geographically in the same place, and until proven otherwise, you can assume that they're sick. Even then, you do have to be careful that we attend to alarm limits to reduce that background bleeping that will distract you from true changes in physiology. Alongside that problem of signal-to-noise ratio, the next problem is one of manpower. Our attempts at cloning juniors to this point have been largely unsuccessful, and you simply cannot be in two places at once. The final problem is that inevitably critically ill patients present themselves at the point when you're least able to deal with them. Everyone seems to get sick at 4 a.m. When you're on your last legs. So we do need to accept that we're human. We don't work in the airline industry, whatever other parallels we're supposed to draw from that. You can't simply have a holiday every 3 days because your job's quite difficult. We do need to simplify all our communication, and we need to have some system for assessment and management that continues to work well long after we don't. So if we look at simplifying communication, you'll be familiar with the SBAR system, originally developed by the US Navy to be used on nuclear submarines. It then got co-opted really by Self for Healthcare in the late 90s as part of its curriculum. And since that time, SBAR has been adopted by hospitals and care facilities around the world as a simple yet effective way to standardise communication between caregivers. So it's really a good way of perhaps either flattening the hierarchy or just giving a common language to everyone who's involved in the care of sick patients. It's hard to talk about simplified assessment and management without mentioning the ABCs, isn't it? The airway, breathing, circulation approach to assessment and management, knowing that a problem in the first will kill you before a problem in the second, which will kill you before a problem in the third, etc. So while it might seem that it's dumbing things down, it has very valid background to it. I would then go beyond that A, B and C to say that we need a see and treat approach. So we need to identify problems in the critically ill patient, but then we need to go on and treat them. It's not enough to simply observe and then move on. We actually need to do something about the problem. And then I've put in tiny letters at the bottom, document it. So it's see a problem, treat a problem, go back, look for a further problem, treat another problem, and then only when all's said and done and the patient has stabilised do we then make sure we write everything down. So we start off with our airway assessment, don't we? A for airway. And the first thing to identify is that airway compromise can take several forms. So it can be sudden and complete, but at the same time it can be rather more insidious and perhaps partial. It can then also be progressive and recurrent. You can largely be reassured by the talk-in patient. So a positive, appropriate verbal response indicates that the airway is patent, that ventilation is intact, and that brain perfusion is adequate. Failure to respond or an inappropriate response suggests that there is an altered level of consciousness, or that there is airway and or ventilatory compromise, or perhaps both. In general, though it's not gospel, if the patient has a GCS less than 8, they may well have a threatened airway, or if they don't at the moment, then they may be on the way towards one. So, in our airway assessment, we're first of all going to observe the patient in general. Are they agitated, which can be an indication of hypoxia? Are they rather more obtunded? Are they knocked off, which is often associated with hypercarbia? Cyanosis is a rather late sign of hypoxia, so it's hopefully rare that you're actually going to see it. Is the patient using their accessory muscles? Are they exhausted? Are they reaching the end of their reserve? You're then going to listen to the patient. So have they got noisy breathing? Because noisy breathing is obstructed breathing. Snoring, gargling, crowing, stridor suggests that the patient has got partial occlusion of the pharynx or larynx. Strange speech suggests they've got a laryngeal obstruction. Have a feel, is the trachea central, or is it being pushed over by some mass, some bleeding, or an infected pocket or something? And then overall evaluate the airway. The abusive and the belligerent patient may be hypoxic, may not just be a bit of a pain in the bum. So when it comes to recognising the potentially difficult airway, I'm neither suggesting that you should spend constant amounts of time trying to do this, or even that you should be experts. It really is one for the anaesthetists, either among you or who could be helping you on the scene. What you're essentially looking for here is you're looking just for that nugget that suggests that this isn't going to be a job for the anaesthetist who last week was the urology FY1, and that you're going to need some senior help. So we use a mnemonic, or I like to, and that is LEMON. You look externally, you evaluate the 3-3-2 rule, we look at Mallampati grading, we look for obstruction, and we look at neck mobility. So first of all, we look externally. Is there just some gross dysmorphia that suggests this patient might have something of a tricky airway? The 332 rule. Can you fit 3 of your fingers in the patient's in the patient's mouth, or rather, could you? You probably shouldn't go ahead and try that. Is the thyromental distance 3 fingers long or more? And is the cricothyroid distance 2 fingers or more? So you're looking for patients who don't have a short thyromental distance that's associated with difficult airway, and a short cricothyroid distance also associated with difficult airway. Malin-Patty score is essentially a grading of how much of the uvula can you see with the mouth wide open. If you ever wondered what purpose your uvula actually served, well, it's for grading your difficult airway. So the less you can see, the higher the class and the more tricky things might be. Look for obstruction. This picture shows a rather nasty tonsillar abscess that could make things difficult. And then finally you look for neck mobility. This chap is well on his way to having a potentially difficult airway. When it comes to managing the airway, you don't really need anything particularly big or clever. A chin lift or a jaw thrust, the latter particularly if you think the patient might have a neck problem, is perfectly adequate, and you can do a whole anaesthetic list on nothing more than a chin lift / jaw thrust, and some people will have been made to do that in training. Nasopharyngeal airway, there's a jaw thrust and a head chin lift. The nasopharyngeal airway is usually better tolerated than the oropharyngeal. That's the oropharyngeal, the Goodell. So the nasopharyngeal is usually better tolerated in the semi-conscious patient, but be really careful not to cause bleeding. So just don't core out somebody's nose for the sake of getting an NP airway in, because once the mouth is full of blood, you've made a potentially difficult airway all the more spicy. The definitive airway, whatever any other brands or drug reps will tell you, equipment reps, is an endotracheal tube with an inflated cuff that lies below the cords. Okay, that really is the only thing that qualifies as a definitive airway. Anything less than that may be perfectly adequate for maintaining the airway, but you do have to recognise that aspiration is a possibility. So we've looked at A. If we now come on and we look at B, we're looking at breathing. So we're looking for a simple breathing assessment. We're looking for a symmetrical rise and fall of the chest, and we're looking for adequate chest wall excursion with that. Respiratory rate is really key. Respiratory rate is the most sensitive marker for admissions to critical care. So tachypnea beyond anything else predicts the patient that's going to find themselves in critical care. You should listen for movement of air on both sides of the chest and in all areas of the chest as well. And you should use a pulse oximeter and record some peripheral SATs. Just be careful that adequate SATs will reassure you that there's adequate oxygenation, enough oxygen is getting into the blood, and it also tells you that there's adequate peripheral perfusion, so those red blood cells are able to make it down to the capillary bed in the fingers. But it says nothing about the adequacy of ventilation, okay? It says nothing about how high your carbon dioxide could be. if you want to check the adequacy of ventilation, the only verified way of doing that, ignoring things like percutaneous Tosca measurement and all that, the only verified way is an arterial blood gas. And an arterial blood gas will give you lots of other useful information as well. It will tell you something of the PF ratio, so how well is the patient oxygenating for the fraction of inspired oxygen they've been given. It will tell you something about the AA gradient. We'll talk more in other sessions about shunt and about dead space. And it will also tell you about the acid-base status of the patient, and it will tell you something about their electrolytes as well, in a number of cases. And really helpfully, it will also give you a glucose. So I'd really recommend an arterial blood gas in the assessment of almost all potentially critically unwell patients. So just a sort of thought experiment for you. You do have to think to yourself, how many arterial blood gases are you going to perform before it would simply be more appropriate to place an arterial line. It could be kinder to the patient, it makes it easier for staff, but it also means you're going to have to move the patient to a level 2 facility where that arterial line can be cared for. So when does that point arrive? Another thought experiment is the potential challenge of asthmatics. It's really helpful to know what an asthmatic's gas exchange is like. At the same time, doing an arterial stab is potentially painful. These are patients who are on maximum sympathetic drive to start with. Sometimes what they need is they need to be sort of helped to calm down, and is stabbing them in the artery gonna help with that? That's your call on the scene, really. Oh yes, so that's the oxygen hemoglobin dissociation curve, which you'll either be pretty familiar with at the moment, or you will be by the end of your placement. And just a reminder of how an arterial blood gas will help you with discerning where you sit on that curve. When it comes to treating breathing problems, well, the answer is almost invariably oxygen. And how much do you give? Well, as far as I'm concerned, the only true answer really is as much as you need, as long as it's been given in a controlled and measured, coming back to how many blood gases you're going to do, in a controlled, measured fashion. Even in COPD, we know that only a small number of patients are actually reliant on hypercarbic drive, but you're going to measure and you're going to watch for those patients. I guess there's also a sort of evolving evidence against hyperoxia in MI patients, but things like that can get somewhat tricky, and really probably just need leaving to trial settings. And for everyone else, it's as much oxygen as you reasonably need. Be careful not to deliver oxygen at a rate that's less than the patient's minute ventilation. So minute ventilation is tidal volume times respiratory rate. You'll have to guess their tidal volume, but it's probably somewhere between 400 and 500 mils. And then there's increasing evidence for humidified high flow in really so many settings. So from post-operative respiratory failure to pneumonia, even to asthma, high flow nasal cannulae really rule on that one. If you start to run out, as it were, beyond that, then you're thinking about giving CPAP, giving positive airway pressure support. You're thinking about NIPI, non-invasive ventilation, and you're thinking about intubation and mechanical ventilation. When it comes to that final point of intubation and mechanical ventilation, you'll find that we are really unkeen on intubating patients on the ward. So we will do everything we can really to safely move the patient off the ward onto intensive care before we intubate and ventilate them, or perhaps in different circumstances that we'll move them to a theatre anaesthetic room. And it's, unless you've actually been involved in anaesthetics, it's probably a little bit difficult to discern why that would be the case, why we would be so unkeen. So just a few sort of highlighting points to sort of help you understand our thinking on these things. So the first is perhaps the human factors thing, and that's to don't underestimate the stress of being outside the normal environment. So on intensive care, we're here every day. We know exactly where all our equipment lives. We can, many of us can sort of reach stuff blind. We know which drawer. We work with the same people day in, day out. Many of them are quite good at reading our minds by this point. So it is really stressful to be outside that sort of comfort zone. The next factor is that the safety of the apneic patient relies on the size of their FRC, of their functional residual capacity. So have we got a picture of that? Yeah, there's a picture of that, just to remind you what the FRC is. So in elective anaesthesia, with sort of normal, otherwise well patients, they can have apneic times of perhaps up to 5 minutes with a normal FRC. But the FRC is reduced with age, it's reduced with obesity, and it's reduced when you're supine. And all of those factors often sort of coalesce in our patients, along with the fact that it tends to reduce significantly in critical illness. So if you watch, but many of our patients are unable to tolerate perhaps much more than 30 seconds of apnea. And that can be frightening and challenging. And if you don't know exactly where your equipment is, it can all get a bit too spicy. The third challenge is that your sympathetic drive is ablated by anaesthesia. So many critically ill patients, they may have a fairly normal looking blood pressure, but what you don't know is that the adrenal glands are absolutely squeezed to the max to maintain that blood pressure. And the only time that you actually find that out is when you subsequently anaesthetise the patient and their blood pressure just tanks. And that's frightening, and you need to know what you're doing if you're going to prevent cardiac arrest. So that's perhaps enough of the anaesthetic scare stories, and we'll move on from B onto C for a simple circulatory assessment. So if we're to reduce this really to the nuts and bolts of things, shock is defined as a cardiac output that's insufficient to perfuse the organs. We'll obviously talk much more about shock as we go through the teaching sessions, but a global definition there. And you can then just use some common sense. If the patient is talking sensibly, then the brain's okay. If they're peeing okay, then you can probably guess that the kidneys are okay. And if they're warm to the touch, then yes, the skin is okay. But just have a think at the expense of what is the patient wildly vasodilated, because of sepsis. Remember that cardiac output is equal to your blood pressure times by your peripheral vascular resistance. Assessing the critically ill on the ward, you're only going to have access to non-invasive blood pressure measurement, but that can nevertheless be quite helpful. And maybe if the cuff is constantly cycling and the staff are trying to tell you that the machine's broken, but you have a hunch that things are different, then you can rely on palpable pulses to a reasonable degree. So if you look at this sort of infogram here, if you can only feel the carotid pulse, then your blood pressure is probably 60 or 70. If you can feel both the carotid and femoral pulses, that's the second group, then your blood pressure is probably somewhere in the order of 70 to 80, just that one outlier where it was 49 apparently. And if you can feel the carotid, the femoral and the radial pulses, then your blood pressure is probably over 80. Okay. If we're to move on to a rather more involved circulatory assessment, then you might want to look at fluid responsiveness. So the Marek definition is used by most of us, and that is that fluid responsiveness is an increase of stroke volume of between 10 and 15% after the patient receives 500 ml of crystalloid over 10 to 15 minutes. The presumption is that if you increase the stroke volume, that you'll increase the cardiac output, and that if you increase the cardiac output, that you'll subsequently increase oxygen delivery. Unfortunately, you'll see that isn't strictly true. And actually there's very little correlation between oxygen delivery on the x-axis and arterial pressure on the y-axis. That's really just a scattergram there, isn't it? So this slide rather puts to death the theory that CVP in some way relates to fluid responsiveness. So many years ago, long before probably many of you were even considering being doctors, it was thought that you put a CVP line in, that you measured patients' right atrial pressure, and that number somehow magically correlated with whether you should give them more fluid or not, and it was supposed to stop you drowning patients with heart failure, etc. But if you look at this, responders marked by R and fluid non-responders marked by NR, you can see that both of them have got CVPs that were anywhere between 0 and 16, maybe higher, when in the trial. So it really is unfortunately nonsense that CVP in any way relates to fluid responsiveness, and very few of us would use that anymore. CVP did, however, sort of lead to a rather more sophisticated theory, which was the use of mixed venous oxygenation. So this is oxygen extraction based resuscitation. So the main factors which influence mixed venous oxygenation are hemoglobin, the arterial oxygen saturation of hemoglobin, cardiac output, and oxygen consumption. And theoretically, if if you keep 3 of these factors constant, then the value of the mixed venous oxygenation reflects a change in the latter. So either cardiac, if you keep oxygen consumption static, or you believe it to remain static, then your mixed venous sats are a measure of cardiac output. That said, there are multiple physiological, pathological and also therapeutic factors which do influence venous oxygen saturation, so anemia, hypovolemia, contractility, bleeding, sedation, fever and pain. So it's not a perfect model by any means. But that said, if you do then plot out mixed venous sats against the sort of the supply to demand ratio of oxygen, you do get something which you can convince yourself looks more of a correlation than those mad scatter graphs of before. So all very interesting on the bench, but what you're interested in is do central venous oxygen sats in any way predict mortality? Well, perhaps yes. So this is a multicenter study, and if you see that mixed venous sats of less than 70% on the left, or hypoxic patients, their mortality rides at around 40%, whereas patients who are described as hyperoxic with mixed venous sats of over 90%, again have high mortality. So what's going on here, if you just think it through, is that if your mixed venous sats are low, then oxygenated blood is leaving the left ventricle. It's coursing around the body, and the tissues are taking up all of the oxygen that they can, and they're then returning heavily deoxygenated blood to the right atrium, and if they're taking up all the oxygen they can, then it may be that there isn't really that much oxygen, so the patient is hypoxic. On the other hand, if the blood is again leaving the left ventricle in an oxygenated state, it's then coursing around the body, but the tissues are badly damaged and unable to take up much in the way of oxygen, then it will return to the right atrium relatively oxygenated. So that again is a poor state to be in, and hence relates to the higher degree of mortality that you see there. Another way of resuscitating the patient is to target lactate. So lactate, the product of anaerobic metabolism, and evidence here that prolonged lactate clearance is associated with increased mortality. This was a surgical ITU. So if you look here, the first group never cleared their lactate, and they had a 100% mortality. In the fourth group, where resuscitation was aggressive and they aimed to clear all their lactate in less than 24 hours, the mortality was very much lower, and groups 2 and 3 are somewhere in the middle. There is something just a little bit squiffy going on, because the lactate levels vary considerably between the groups, and the predicted mortality is also different between the groups. So it's not your ideal paper, but it gives you a hint of how clearing lactate might be good for you. So this was a different paper. So here they're looking at lactate-guided therapy in ITUs, a randomized control trial here, and here versus a control group when they targeted lactate resuscitation. Mortality was significantly lower, so relative risk of it's about 20% better, isn't it, of in-hospital mortality and as well as ITU mortality when you target lactate clearance. Yeah, I've actually highlighted the adjusted figures, but you get the theory there. Useful to think for a moment about the passive leg raise. The passive leg raise is a really neat trick to sort of reversibly give somebody a fluid bolus, as it were. So the volume of blood transferred, which is usually about 200 ml if you empty your legs towards the heart, is sufficient to increase the left cardiac preload and therefore challenge your Frank-Starling curve. So you should see a maximal effect somewhere between 30 and 90 seconds, and what you're looking for is a 10% increase in stroke volume if you're in a position to measure stroke volume, or at the very least some surrogate like your pulse pressure on the arterial waveform. So a neat way of giving a fluid bolus, but knowing that if you're wrong, that you'll soon be emptying it away from the heart when you put the legs back down. So we've looked at assessment of the circulatory system, and now we need to look at treating circulatory problems. And the first thing to say is that you do need to ensure that the circulation is intact. And it sounds really obvious, but the number of times that we've come unstuck from not attending to this. So does the patient have a hole in a major blood vessel? If they do, what's the right way of managing that? Does the patient need endoscopy? Do they need surgery? Do they need interventional radiology to perhaps coil something off? But just know that you'll never be able to balance the circulation unless it actually is going round and round and not pumping out. So the next thing to do is then to fill the circulation, and you have to think about what the most appropriate fluid to fill that with. Is the patient anemic? Have they bled out? In which case the only fluid which carries oxygen around the body, whatever the orthopods say, it's not cefuroxime, it's blood. If they haven't bled out, if they're non-anemic, then you're going to give them fluid, and you can read 1,000 fluid papers and not come to any conclusion about what you should use. So that's the wisdom of Derek Angus. Really, as long as you're monitoring what you're giving and you're measuring it and you're evaluating it, you can really give what you like. After that, you're looking at manipulating the circulation in some way. So that's use of inotropes and vasopressors, and we'll talk more about that in other teaching sessions for sure. That's a really interesting and useful topic. And you then need to think about why is the circulation disturbed? What's going on, and look at treating the underlying cause. Is the patient septic? Does the patient have an underlying cardiac issue? And proceed from there. So we've looked at circulation, come on to D, looking at neurological assessment. Simply things you can do with the patient in front of you. Glasgow Coma Score, particularly helpful. Just my little nugget there of remembering that you are looking to test the patient's response to a painful stimulus, not simply to some mildly arousing stimulus. So not unusual for the patient's GCS to miraculously improve when they meet a critical care consultant, and it takes a bit of practice, but do make sure that you're assessing in a thorough fashion. Don't forget to measure the patient's glucose. I've been caught out by that more than once, and you look a bit of a prat. And also don't forget to look at the drug chart and to talk with the ward staff and to unearth that big dose of opiates that they were given on top of their renal failure that nobody knew about. More advanced neurological assessment requires something like a CT scan, or the donut of death, as we know it. So the problem with CT scans is that you're taking the patient from a relative place of safety, like the ward, to a place where they're going to be minimally monitored, and they're really hard to get to if things go wrong. So, you've got to do a risk assessment on, is this the right thing for the patient right now? CT scans with sedation, they're probably even worse. Sedation is essentially AWAC, that's anaesthesia without airway control. You're taking somebody who's not neurologically intact, you're then giving them a drug that's going to make them more drowsy, and then you're going to shove them through a CT scan where you're neither monitoring them or able to adequately treat them. Is that the right thing for the patient? Is that the wisest move at this time? Leave that with you. Or lumbar puncture, another advanced neurological assessment. So I'm going to come into land there, just with this conclusion. There really isn't anything particularly difficult about managing the critically ill patient and assessing them on the ward. It is time and resource consuming, and that's probably one of the big areas that critical care steps in, is allowing ward-based doctors to devolve responsibility and being able to be more attentive to the patient. If we adopt a simple approach to both our communication and to our treatment, then outcomes will hopefully improve. So I'll leave that there, and I'll happily take any questions you have on that.